seven bones, right? Here is the frontal bone, this is zygoma, this is maxillary, and inside we have ethmoid, lacrimal, and in this slide may not be visible, but it is a visible sphenoid bone and palatine bone. So we have the frontal process of the zygomatic bone and zygomatic process of the frontal. This is frontal process of the zygomatic bone, zygomatic process of the frontal bone. And here we have the maxillary bone and so on and so forth. Coming to our main topic of the day is the orbital floor fractures. We have heard the word or the term blowout fractures, and that is our topic of today, which is mostly the infraorbital fractures or the orbital floor fractures. Here you can see what anatomy we have inside the orbit: the superior orbital fissure, inferior orbital fissure, and optic nerve foramen. These three structures are very much important because if there is any trauma, we may get patient with superior orbital fissure syndrome or optic nerve syndrome. Basically, optic nerve syndrome is a misnomer, and it is the term better is that optic nerve, if it is destroyed, then there is loss of vision. And when there is superior orbital fissure syndrome, the cranial nerves number 3, 4, 6, and the trigeminal nerve ophthalmic branch is damaged or have involvement of these nerves, which have different manifestations, which we all know. The patient will have complaint of diplopia, will have difficulty in movement or in the lateral gaze, and there will be loss of sensation or over the cheek area, right? Here is one of the picture which is of a slide of the coronal view of CT scan. Here we can see the orbital floor is fractured and the orbital content has entrapped into the maxillary sinus. How blowout fracture occurs? It may occur by the direct impact. For example, the tennis ball, which is larger in size of that eyeball, and you can see there whenever it has trauma with it, then the orbital floor is disrupted. And whenever it is disrupted, then the muscles, which are extraocular muscle or recti, are entrapped inside the maxillary sinus, which may produce a teardrop sign. And the patient will complain of hypoglobus along with that epiphthalamus and diplopia, beside the aesthetic reasons. There is another example which shows a fist which is on the direct globe. Here again, you can see the tennis ball or any cricket ball which has hit the globe and resulted in fracture of the orbital floor. And mind this, that orbital floor is the weakest of all, and second is the medial wall. Here, in this picture, if you can see, you will see that there is one blow by the fist directly to the globe, and the other is below the globe area. So the one which has the direct force to the globe, you'd appreciate that there is not a fracture. There is a fracture, but again, in the second picture, you can see it is not directly hitting the globe, but there is fracture too. For this slide, I will explain it with the help of the hydraulic theory versus the buckling theory. Uh, Buckling theory, which is also called as bone conduction theory, is having less severity or less energy. Small fractures are resultant in the interior floor. Hydraulic theory is a theory which states that there is larger fracture involving entire floor and medial wall, and it occurs due to the pressure effect which is created over the globe that is directly traumatized. In this slide, you can see what we can see that there is a fracture line in the infraorbital rim area, and the orbital floor too is fractured along with the medial wall.
Excuse me, Dr. Tanvir.
Yes,
Can you full screen it?
I think it's full screen enough. Okay, one second.
Kindly make presentation on.
Okay, this is better, right?
All right.
Is
Thank you
it
so
better
much.
now?
Yes, it is better now.
Here in this slide, you can see again the CT scan slide, which is of a coronal view of the, and you can see the orbit. And there is disruption of the orbital rim and the teardrop sign, or it's not a small teardrop, it's a big teardrop sign, means the orbital content has sunken down to the maxillary sinus. So for reminder, our review, we can see it again. The direct impact and the indirect impact. And with the direct force to the globe, which creates pressure inside the globe, would result in the fracture of the orbital floor, and here it will also result in the medial wall fracture in the second slide. Medial wall is slightly thinner, 0.5 millimeter versus 0.5 millimeter of the floor thickness. So medial wall would be always or most of the time suspected with the fracture of the orbital floor. And it can be confirmed through investigations beside clinical examination. Here, the purpose of this slide in this presentation is that ocular muscles are very important in judging which part or which muscle is entrapped or having entrapment due to any part of the orbital floor fracture. As our presentation is focused on the orbital floor fracture, so I'm sticking to it. Otherwise, there are all these muscles may have entrapment in one or the other fractures, because it is not only that there would be orbital floor fracture or medial wall fracture, there might be supraorbital rim fracture, lateral wall fractures, or orbital floor fracture along with the other fractures. Lateral, there are the recti muscles. They are lateral, medial, superior, inferior muscles, four in number, and they are superior oblique muscle and inferior oblique muscle. And we know that the recti muscles are those muscles which have direct attachment to the eye globe, and they pull or pull down, pull up, pull down laterally or medially the eyeball. Okay, but we have the oblique muscles which are lying oblique to the globe of the eye. Like for example, here we can see the superior oblique muscle, or here it's not visible in this slide, the inferior oblique muscle. And mind this, that inferior oblique muscle has the name though it is in the superior position, and superior oblique is in the inferior position, but it has the name of superior oblique because it has the lid, it has the movements. Extraocular muscles. Here we can see the superior oblique muscle movements um, in this slide of this patient. Now coming to the investigations. Physical examination is the first and foremost thing in any fracture. A full head and neck examination, cardiac examination here is important whenever you have the injury to the orbit, because we know about one term that is oculocardiac reflex, which has triad of nausea or bradycardia. And it is an emergency situation. We have to explore the globe in emergency. Then third thing is the facial asymmetry. You can see there is asymmetry in this slide. Um, then is the cranial nerve examination of trigeminal nerve, maxillary division. Examination of the canthal stability is important too. Bowstring test, but not in the initial physical examination. Then you can check for any entrapment of the extraocular or intraocular muscles, and that is done by uh, um, eight, eight directional test. The pupillary examination is important in a sense that you have to see the distance between the pupil and the pupil size. Pupil size is important because if there is dilation of the pupil, it may indicate any severe severity like superior orbital fissure syndrome or the hematoma of the orbit. Uh, so that is important. Then is a retinal examination. You can initially check for any retinal detachment, and that patient should be referred to ophthalmologist or oculoplastic surgeon. Then is exophthalmometry, and with the help of exophthalmometry, you can see anophthalmos or exophthalmos. But in these cases, we have the anophthalmos. Here, this slide shows there is very difficulty of movement of the eye due to entrapment of the extraocular muscles. And the six cardinal signs of gaze are affected. The inferior rectus muscle has become stuck in the fracture, preventing patients from looking directly downward. Coming to the orbital blowout fracture, usually inferior wall, since is weakest, is fractured, and along with that, plus minus medial wall would be fractured too. The signs, as you all know, that it's diplopia. Diplopia sign is one of significance, and it may be due to the reason that there is entrapment of the muscles, and that should be excluded beforehand, because if there is any neurological reason for the diplopia, that neurosurgeon should be consulted. Um, Tethering of the inferior rectus prohibits upward movement of the globe, and proptosis means the bulging out of the eye or swelling due to the swelling or retrobulbar hemorrhage, and later on anophthalmos from the loss of volume, as we know that the volume is sunk into the maxillary sinus due to entrapment of the muscles too. Uh, the major reason is the fracture. 30% incident of ruptured globe in conjugation with the orbital fracture is reported, and the reference is a bit old one, but it is widely accepted. Consequences of the orbital floor fracture. Entrapment of the inferior recti or orbital pad occurs, and loss of inferior rectus muscle function is due to entrapment of the muscle within the fracture, edema and hemorrhage of the muscle, and extraocular fat perhaps to fracture of the maxillary sinus. Moreover, as I have mentioned about some emergency situation, right, like retrobulbar hemorrhage or superior orbital fissure syndrome or apex syndrome or loss of vision, those are priority basis um, situations in which an emergency operation theater should be arranged. In this diagram, you can see uh, nicely how the fracture of the orbital floor has occurred and what it has resulted, though it's very small in size, but you can appreciate it. And there is teardrop sign too. So again, we are to the slide having eye movements of lateral recti muscle, and lateral recti muscles movement is disturbed due to fracture. Here you can see the superior oblique muscle movement, and you can appreciate in the slide that there is entrapment of the superior oblique, and the movements are not well in the picture. Clinical significance of intra-orbital structure, orbital trauma may result edema or hematoma within the internal orbit. Orbital flow, blowout fractures increase the intra-orbital pressure and that comprise the intra-orbital neurovascular structures. This is something very much important, which the patient may get loss of vision permanently, and you may need to have a prompt action. So, diagnosis is based on sign and symptoms along with the examinations. CT scan is of gold standard, and the clinical examination is on the slide. That is limitation of the eye movements, when there is severe orbital pain, diplopia, nocturnus, loss of sensation due to infraorbital nerve injury, orbital and lid subcutaneous ecchymosis, or emphysema. Here you can see ecchymosis and emphysema. Emphysema cannot be seen here. It can be felt with on palpation. Diplopia, as I mentioned, that in the 8 gaze, you have to ask the patient to have the eye movement, and ophthalmos is on gross examination, bird eye view. You will appreciate an ophthalmos, that is the eye is below the normal orbital rim structure, and it is inward movement. Okay, orbital pain, as I have mentioned some of the syndrome names, and it may the most probably and most commonly in superior orbital fissure syndrome or retrobulbar hemorrhage, apex syndrome, etc., do have the orbital pain. This is a test performed with topical anesthesia, but most commonly it is done under the GA. And the extraocular, now the recti muscles are forceps and then used to grasp the conjunctiva, tendon capsule, and just pursue to the limb. Asked in the setting of anesthesia, help in the see moments on examination, but it can be observed during clinical examination. Periocular ecchymosis and edema is very much visible in this slide, and hypemia is the blood collection in